Hello, everyone. My name's Tash Oaksmonger. I work for NHS England as the National LGBT Project Manager, and my pronouns are they, them. I'm just going to talk a little bit about language, about some of the basics around concepts around trans and non-binary people, and then some of the health inequalities that this group face. So, a bit about why this work is really important. So I want this to feel relaxed and collaborative. And as Anne-Marie already mentioned, it's really important this is a learning space. So you should feel able to ask questions without worrying about how you phrase them. Sometimes people worry and they say, oh, I don't know how to ask this. Ask it how it is in your head. If you say something that is maybe a bit clumsy or the wording isn't right, I'll let you know how to ask it next time. But we are giving explicit permission for this to be a learning space. So ask those questions. And if there is anything inappropriate, we'll just ask for that to be taken offline. I haven't oversimplified stuff super a lot, so if anything is challenging or confusing, that's why this is in a learning space. That's why we say we want you to ask questions. And this work is really important. I think it's good to acknowledge the environment that this is taking place in the context of this country, where we see the discussions around trans people becoming quite hostile, and the environment for trans people is quite hostile. So really, really important that we have these discussions about a community that faces a lot of health inequalities. So to start with, language and ideas are really important, and I think it's really important that we get kind of a grasp on some of these concepts. So sex, gender, and orientation is where I'm going to start. These are three different things. They're not binary and they're not fixed, and each person experiences them differently. And those experiences might be different from what you expect or from societal expectations. So, sex is something that is assigned to a person on the basis of primary sex characteristics. Gender is often expressed in terms of masculinity and femininity. It's largely culturally determined, and often we assume it from somebody's sex assigned at birth. And finally, orientation, which is an umbrella term describing someone's attraction to other people, so sexual attraction or romantic attraction. So going into that in a bit more detail, assigned sex is assigned to a person on the basis of their primary sex characteristics, so their genitalia and their reproductive functions. And there are also people who use the term intersex, and that is a term used to describe someone who might have biological attributes of both sexes, or whose biological attributes do not fit with societal assumptions about what constitutes male or female. Now, not everybody uses the term intersex. Some people prefer variations in sex characteristics or differences in sex development. And a theme that you'll see running through these kind of discussions is that respect is the most important thing. So if somebody uses a certain term about themselves, that's the term you should use for them. You don't have to understand every single term, just within the same as when we have any kind of clinical practice. You don't necessarily understand everything about someone's experience, but it's important to respect that and use the language that they've asked to have used about them. And then gender, so this is often expressed in terms of masculinity and femininity. It is largely culturally determined, and there's several different words that you might hear in this space. So to start with, gender expression. This is about how someone chooses to outwardly express their gender. So that could be how they dress, how they act, how they interact with people. And a person who does not conform to societal expectations of gender may or may not be trans. So just because you don't conform to societal expectations of gender, that does not make you trans, but some people might be. And then next is gender or gender identity, which is someone's internal sense of their own gender, whether that be that they are male, that they're female, that they're non-binary, or another gender, and that may or may not correspond to their sex assigned at birth. So the next two words you might be less familiar with, but cisgender or cis is somebody whose gender identity is the same as their sex assigned at birth. So non-trans is also used by some people. And if it helps to remember, cis, the word cis is a Latin word meaning on the same side as. So we're talking about people whose gender is on the same side as or is the same as their sex. And then finally, trans, which is from the Latin word, which means across or beyond, so on a different side from. So this is an umbrella term used to describe people whose gender is not the same as or does not sit comfortably with the sex they were assigned at birth. I've put a few more gender descriptions on the right there. They're words that you might come across. Again, it's not about necessarily knowing and understanding what every single one means, but it's about respecting that if somebody is using that language. One that is useful to know is non-binary, which is when it's another umbrella term used to describe someone whose gender does not fit comfortably into male or female. And for those individuals, they may reject the gender binary, or they may identify with parts of it, but not all of it. So it's a very individual thing. And then finally, pronouns. I've written some down here for you. I'm going to talk a little bit more later about why pronouns are important and how to use them. But I just thought I'd put them on there so that you can recognize some of them. And in this presentation, that little exclamation mark is just a reminder of where words might have previously been used that are perhaps outdated, or are clumsy ways of phrasing things, and they'll appear there. So you can see some of those terms there. I've just seen someone asking about citations available for definitions. Generally, the Stonewall Glossary is a good place to start. I just wrote these definitions myself, so probably not easy to cite them from there. But the Stonewall Glossary, which you can find online, is a really good place for citing definitions. And finally, orientation is an umbrella term when used for describing someone's attraction to other people. So that might be sexual attraction, so who you want to have sex with, or romantic attraction, who you fall in love with. And these terms refer to someone's sense of identity based on their attraction or lack thereof. So you'll probably recognize most of these terms, but to go over a few that you might not recognize, when we're talking about bisexual people, we're talking about people who are attracted to two or more genders. When we're talking about pansexual, we're talking about people who are attracted regardless of gender, and asexual, people who experience less or no sexual attraction. So I think it's just important to distinguish that although some of these concepts are connected, they are also separate, and aren't necessarily the same thing. And someone can be lesbian, gay, bi, pan, asexual, and also be trans or non-binary. Language is really important because trans people use a lot of different words to describe themselves. Lots of the words that we use are about signposting. So it's not about conveying exactly everything about who you are. It's about signposting something about how to treat you and how you move through the world and how you want people to treat you. And language is evolving all the time. So that's a really positive thing. As language evolves, we are able to more clearly articulate our experiences. But that does mean that in order to stay on top of language evolution, you need to be involved in trans and non-binary communities and LGBT communities. So I would suggest carrying on this education, consuming content from creators, and making sure that you are kind of moving along with that language evolution. And as I said before, the most important thing is that you are treating people with respect in this process. Even if you don't completely understand every aspect of people's identities, it's important to respect them. And pronouns, names, and talking about trans people are really, really important. So I've written a little bit more about this. When we're talking about pronouns, we're talking about the small words that we use in place of someone's name when we talk about them. So, for example, he, she, they, you are all examples of pronouns. Oftentimes, when we use these words, we use them and we implicitly link them to a certain gender. For example, he used to refer to a boy or a man, or she used to refer to a girl or a woman. These links aren't always helpful, especially when we're making assumptions based on someone's name or how they look or the sound of their voice. It can send a message that there's a certain way to look or sound in order to be a certain gender. And that might be fine for you if everyone always makes the correct assumption about you, but it is particularly uncomfortable when people don't make the correct assumptions about you, and that can be very painful. And using someone's pronouns correctly is a sign that you respect them and you see them for who they are. And actually, it's more than that. So, one of the things that I talk about a lot is that getting someone's pronouns right is actually a really big thing for some people. And this isn't just about helping people to feel accepted and welcomed, but this community, for whom this is especially important, the trans and non binary community, reports some of the highest rates of suicide, depression, and self harm. And ensuring that people are referred to using their correct name, their correct gender, and their correct pronouns is actually critical to reducing these risks. So some of the research behind this, this was a piece of research done that showed that for each additional context where a trans youth's chosen name was used, their risk of suicidal behaviour was reduced by more than half. So really, really significant impact on these young people of actually affirming their name in different environments. So for each environment, home, school, at work, with friends, that they were getting their name respected, their risk of suicidal behaviour was reduced by more than half. And we also saw this for pronouns. So research from the Trevor Project found that trans and non-binary youth who reported having their pronouns respected by all or most people in their lives attempted suicide at half the rate of those who did not have their pronouns respected. So this isn't just about making people feel more comfortable. It's about safety. It's about people feeling safe to access care, and it's about suicide prevention. There are lots of differences when we're talking about someone coming out as trans or non-binary, and there are lots of similarities. It is likely taken the individual a long time to get to the point of feeling comfortable to come out. But there are differences. If you are undertaking any form of medical transition, it can be very difficult for that not to be obvious to everyone around you. So that creates a difference in how people may respond. It's really important not to assume that everyone wants to be responded to in the same way. I think the really important thing when people are coming out to you is thinking about autonomy. So giving people some space to make decisions for themselves. And some classic not to do things are to ask people if they're sure. If they're coming out to you, they've probably thought about it for a really long time and probably gone through a lot to get to the point of trusting you with that. And not to ask people about whether they're going to have certain operations or what medical transition they're seeking, because that's an inappropriate conversation to have with someone unless it's clinically relevant in your practice. I'm finally going to just talk a little bit through some trans and non-binary healthcare inequalities, which I think is really important. Firstly, this is a piece of research that followed a group of children from the age of 10 up to the age of 21. And when along those years, they asked these children to fill in mood and feeling questionnaires, which is a questionnaire used to kind of identify where people might be experiencing mental health issues. And what they did was then when this group of children turned 21, they asked them about their sexual orientation, and then they split the groups by the straight group and the sexual minorities, and they plotted back. And I think this graph is just really important because it shows actually that these children were experiencing significant difference in mood and feelings from the age of 10. Even if they hadn't, come out to others or come out to themselves, that difference in experience of mood and feelings questionnaire was seen from the age of 10. So really important to acknowledge that these differences are seen actually in early childhood, and even if individuals don't necessarily kind of define themselves in that way yet. The second study that I think is really useful to challenge these assumptions is one that looked at ischemic heart disease, and this was looking at risk factors and what was predictive of outcome after acute coronary syndrome in young people. So what they did in this study was they took a group of men and women with ischemic heart disease, and they asked them to fill in personality questionnaires and personality trait questionnaires. And what they found was that those who had scored highly on feminine roles in these questionnaires had an increased risk of ischemic heart disease independent of their female sex. So I think this is important because it's a study that suggests that actually perhaps gender was a more predictive factor, and gender roles were a more predictive factor than sex in this study. And I think that's important because it can be very difficult to distinguish between the two when the vast majority of the population, their sex and gender align. So I think in clinical medicine, sometimes we make assumptions about the power of understanding about someone's assigned sex, and sometimes forget to look at some of the gender effects that could be going on. So trans and non-binary people experience healthcare inequalities in many, many areas, some of which you might have thought of, such as mental health, maybe primary care, sexual health, but there's lots of other areas where LGBT people face health inequalities. So all of these areas are spaces where our team has worked in, where there have been issues. I think one of the biggest areas is often mental health, so anxiety, depression, self-harm. This is just some studies. Don't worry, you'll get the slides after so you can have a look through them. But this is just some links to some studies of areas where we see trans and non-binary healthcare inequalities. And unfortunately, because we don't consistently collect data on trans and non-binary people, it's very hard to access data from within the NHS. So this is a survey from Stonewall, which is also very useful, and you can go away and use some of the stats from this. This looked at LGBT people's experiences and found very high rates of mental health issues in this community. And also that when people did access care, they often had unequal experiences of treatment and were even pressured to suppress their gender identity when accessing healthcare services. Another area where we do have some data is from the National LGBT Survey from 2019. This is one of the largest LGBT surveys that's been undertaken. This was undertaken by the government, and the government found that 40% of trans respondents who'd accessed or tried to access public health services reported negative experiences. I would suggest that this is probably much higher now after media kind of scrutiny in the past few years on trans identities. And we see a lot of different ways that this can be seen. So, inappropriate questions or curiosity, needs being ignored, fear of discrimination, and then actual experiences of discrimination. So, when we're talking about people being afraid of discrimination, oftentimes that is because they have previously had an experience, a direct experience of discrimination. We also know that many people have changed their GP due to negative experiences. And we actually know that trans and non binary people do hold informal lists of GPs that are safe or not safe to attend because of where they are able to access trans affirming care. And finally, this is just a study looking at outcomes to be taken with a pinch of salt because it's done in the US. And obviously, the United States healthcare system is very different from our own. But I think it's important to acknowledge that even in our healthcare system, we will see the effects of socioeconomic factors. And it's important to take those into account. So we know that trans people also face inequalities in employment and education and housing, and those will also have an effect on health. So this study found that trans people who had cancer were more likely to be diagnosed at later stages, less likely to receive treatment, and had worse survival for many cancer types. And unfortunately, we cannot see whether that is a similar picture in the UK because we simply do not collect data on this community. And finally, just before I've got a couple more slides, some of the areas where we might see discrimination are microaggressions. So microaggressions are small actions, behaviors, phrases, words, language that we use which contribute harm to oppressed groups. So we're talking about making assumptions. We're talking about cis normativity. So that is where we assume that everybody is cis or everybody is not trans. The language we use, the way we react to when someone comes out to us, and dismissal of identity. So seeing someone's identity as not real or not valid. These are all examples of microaggressions. And this is just an image of what that might look like. So this is a trans man going for a cervical screen. And this is something that we hear a lot from the trans community, that this is really difficult, cancer screening. And as you can see, he's walked into a space which clearly isn't inclusive of who he is and his experience. And that is something that might put him off attending or re-attending in the future. And finally, intersectionality. So this is a term that was coined by a Black feminist, Kimberly Crenshaw, and she speaks about how people's identities are made up of multiple different aspects, and those identities intersect or crossover, and where they cross over, they create very unique experiences of oppression. So a trans person's experience, a trans person who is white, their experience will be different from a Black trans person, and a trans person who's disabled will experience a very unique form of oppression that is different from a trans person who isn't disabled. So it's important to remember that gender diversity is widespread. It's not something new. It's been around for many, many years across the world. There are actually many countries in the world where third genders are legally recognized, such as Iceland, Malta, India, Pakistan. And so it's important to remember that this isn't a westernized concept. Obviously, the language in this presentation is kind of catered around the westernized view, but it's important to remember that this isn't just something that we see in the West. People have intersecting identities, and where these identities intersect, we see multiplying barriers. So not just the additive barriers, but multiplying barriers for those individuals who have multiple sites of oppression. And that's why it's really important to acknowledge our privilege and power, and to use our power to remove barriers for groups who experience oppression, and that could come in the form of representation or access needs and accommodations for those individuals. I'm aware that we're tight for time, so I'm going to finish there. I've got a few slides at the end, which I won't go through, but these I will just show you that they are there when they get sent round. These are just practical things around using pronouns, what to do when you get things wrong, how to correct yourself when you make a mistake, and things like that, and top tips. So you will get the slides after, but they're more for just reading in your own time. And you'll have time to ask me questions after Catherine's presentation. So I'll hand over to Catherine now.
Thanks, Tash. I'm just going to try and share my screen with you all. Just bear with me a second.
Thank you, Tash. That was great. Looking forward now to hearing from Catherine. I started speaking when I was still muted. Classic.
There we are. Can you all see the presentation on the screen? Somebody could just give me a yes.
Yes, we can. Yep.
Great, thanks, Anne-Marie. Hi, I'm Catherine Cobley. I'm the Diversity and Inclusion Manager over at Howell Dda University Health Board. I've been working within the field of equality, diversity and inclusion for a long, long time. And what I would say is I would definitely say within the last 4 to 5 years, so definitely pre-pandemic, gender diversity, transgender, I hate the word issues because it makes it sound like as though it's a problem, but definitely concerns, some queries, they're definitely on the rise. Definitely, I'm seeing a larger amount of more complex queries landing on my desk. So massive thanks to Tash, who's just talked you through some of the terminology, how best to deal with some transgender, gender diverse people. My presentation is going to focus more on sort of the legislation that is in place now for public sector bodies, so for NHS. I'm going to look at some of those concerns, the queries, the issues that have sort of been raised within the past few years within our health board, and the steps that we are taking to try to resolve these issues and to address them to improve the experience for all who are accessing services within the NHS. Just bear with me. I'm not going to play the video because the video doesn't exist anymore. But what I will do for everybody, there's a series, it's Scotland Bite Size. So there are a series of sort of videos which follow the experiences of a trans teenage girl who's in college. They're very, very good. They're bite size, and it's all about sort of misgendering, experiences, that type of thing. I will pop a link in the chat bar to the whole series, and then you can just dip in and dip out if you want to learn more about that. So we've got the Gender Recognition Act from 2004. So some of you might be familiar with this piece of legislation, some of you might not. Obviously, the Gender Recognition Act was introduced to improve the experiences of gender diverse people, to give them more rights when they're accessing public sector services, to give them better equality, that type of thing. But it's important as well to remember that we have other legislation as well, which are intrinsically linked then to this Gender Recognition Act. So I expect you've all heard of the Equality Act 2010, which again offers some protection as well for people undergoing gender reassignment. We've got the Human Rights Act as well. But equally as well, then I think it's important for us to note that even though these pieces of legislation exist, they are forever being reviewed as well. So as some of you might know, and rightly so as well, because no piece of legislation should be put in place and then because things change, we do need to be constantly reviewing these pieces of legislation. And as you know, we have the Human Rights Act reform, so where we're looking to propose a new Bill of Rights. It's a debatable subject, as you all know, where there have been lots and lots of protests going on in London around that reform there. But at the same time as well, we've also got the reform of the Gender Recognition Act, because when that act was introduced in 2004, it was a fairly new, a fairly revolutionary piece of legislation. And of course, since that has been introduced, new things have come to the forefront. So that act does need to be reviewed and maybe need to be amended or slightly adjusted, equally to say that the act didn't quite go far enough then to offer equality for gender diverse people. So again, key points of interest around the Gender Recognition Act. So it enables those with gender dysphoria to legally identify themselves as the gender of their choosing. This is done via the application and the issuing of a gender recognition certificate, which you all might have heard of. It provides safeguards for the privacy of individuals with gender dysphoria and restricts the disclosure of certain information. So it makes it an offence to disclose protected information. So for example, a person's gender history after that person has changed gender under the Act, when that information is acquired in official capacity. And also we've got the PDS NHAIS guidance stating that the patients who are undergoing the transition process are also entitled to the same special protection against the disclosure of their gender history. And the Gender Act reform, as I just spoke about, it seeks to make this process a lot easier for people. And the BMA are in support of this reform as well. So they are in support of scrapping the need for a medical diagnosis in order for a person to obtain a gender recognition certificate. So there are some that think that even though, yes, it's great that we've got this Gender Recognition Act 2004, it doesn't quite go far enough, and there is still a lot of red tape, as with any sort of piece of legislation. So the reform is really looking to make it easier for people who are gender diverse to live their lives as they want to live them without being discriminated against. So what does this mean for the NHS? The key points, I think, the key points of interest for us to consider here as healthcare clinicians and medical staff, patients have the right to request for a new NHS record to be recreated in line with their gender identity, or patients have the right to request for their gender to be amended on their current NHS patient records. And it's from this sort of right that patients now have that some of the issues are coming to the forefront that we need to address and resolve. So if a patient chooses to create an entirely new NHS medical record in a different gender, what could possibly be those risks and implications? So as we all know, working with NHS, our current NHS systems, they're just so old, and I know we all complain that some of them they're just not sophisticated enough, if I'm being honest, to collate gender data effectively. I know Tash referenced several times in the presentation earlier about the fact that this data isn't collated, and I think the main reason for that is that the systems just don't allow, they're just not sophisticated enough for that data to be collected efficiently, and so we can use it to see what that data is saying. So obviously current NHS systems, they're not able to link previous medical records to new medical records. So there's a risk then also that the previous medical record may be deleted if it's dormant. So in line with GDPR records, I think, don't quote me on this, I think if an old NHS record is lying dormant for around 8 years, that will just be deleted. So you're also deleting a patient's sort of gender history, you're deleting the medical history, that type of thing. And of course, another implication and another clinical risk, we do have clinical staff who are dependent upon what current existing patient information systems hold to obtain an accurate gender status and gender history. So as you can see in the right-hand column, some of the services who have raised concerns with myself, blood donations, gender-specific cancer blood tests, organ tissue donations, mental health patients, maternity, sexual health. So we have all of these services, and more recently, just within the last fortnight, I've had to help our dietitians as well with their referral form, because they're another department, especially paediatric dietitians, where they do have a clinical reason for wanting to know the biological sex of a patient coming to see them. And like I said, the problem that these departments are having is that they are often dependent upon our patient administration systems to give them that accurate information, where the Gender Recognition Act has allowed somebody to create a new medical NHS record, which might not hold all of that information that the clinician needs. And then obviously for the second scenario, almost contradicting what I've just said, if a patient chooses to amend their gender on an existing NHS medical record, that perhaps might leave us open then to outing that person. So we may have some older records which retain a prior gender status. There's a risk that that patient becomes identifiable as transgender or gender diverse. And then again, gender history is not clear to clinicians who need it for clinical purposes. And again, our services who have been affected by this, who have raised sort of queries with myself, our medical records team and various individual teams. So the solutions, it's really, really difficult when we are talking about the IT systems really that we are using, our patient administration systems. It's not an overnight thing that can be resolved. We have here in Wales, we've escalated issues to Welsh Government and the UK Government actually via our national peer group. So when they are looking at the Gender Recognition Act review, that perhaps they can give some consideration to the fact that the NHS actually needs a more effective patient administration system to allow us to gather the data that we need, not only for clinical reasons to avoid any clinical risk, but as Tash said as well, to sort of allow us to collate data more effectively going forward in the future for research purposes as well, so we can gain a better understanding of gender diverse people. We're also exploring options for amending current patient administration systems in order to capture gender status and retain information on gender history at the same time. So here in Wales, we are looking to develop an almost like a mirror system. So where if a person has created a new NHS medical record, the previous NHS medical record can be held on this system, which will follow the new one. Almost in a mirror fashion right throughout that. But again, that's something that's being developed. It's not going to be developed overnight, and it will take a lot of capital investment as well to develop that system. We are exploring options just for retaining and linking previous medical records to newly created ones, and also ensuring that any new patient administration systems going forward, that they are set up to collate gendered information appropriately. So back in February, I was working with some colleagues on the LIM system. So obviously quite key that they need to know certain information about a person's gender history, about the biological sex, about the treatment that they're receiving when they are looking at certain blood tests, that type of thing. So they are now looking to create a national LIM system, and what we're hoping is that they will get it right as well, and can be that can be used as an example of good practice, where we can collate the information we need without people having to handwrite notes on test results. Because like I said, when it comes to people handwriting assumptions, making assumptions or handwriting information about a person's gender onto medical roles, are we then at risk as well then of outing people accidentally wherever those results are going to be sent? And conflicting legislation. So quite complex. So as we know, we've got this Gender Recognition Act, which is great. We've got the Equality Act, we've got the Human Rights Act, but we also have a lot of other legislation as well, which can sometimes, as these sort of issues and queries are falling on my desk, you can see that there is a little bit of conflict with other pieces of legislation and code of conducts as well. And again, it's another challenge for us to overcome. So we've got the Mental Health Act Code of Practice, which states, so this is an example that landed on my desk. So we had a trans female mental health patient who required a long-term secure unit placement. Well, of course, the Mental Health Act Code of Practice states that patients who require long-term secure unit placements must be placed either on an all-male secure unit or an all-female secure unit. So where did we put this patient? And what we had to do, because we thought, well, we can't be the only organisation that has faced this issue at the moment. So we linked in with local prison services, because again, it would be very, very similar there. If you had somebody who required imprisonment and they were a transgender person, do you send them to an all-male prison or an all-female prison? Because you have to look at what's going to be best for that particular individual, because either, you know what I mean, by placing them in one or the other, it could both have a harmful effect and a harmful impact upon that individual. So the advice we took was to set up a multidisciplinary panel to look at the individual case in question. That multidisciplinary panel not only needed to include the mental health staff dealing with the patient, it had to have people from the trans community. You had to have independent members. You had like people like myself. You know what I mean, that type of thing. So you were really sure that you were gaining the perspective from all sides then, so you could make a decision on what would be best for this particular individual. There was also a request to develop clear guidelines, because those guidelines on a national level, they're just not there. I know, because I searched for them at the time and they're just not there. So we are pushing government and NICE and other organisations to develop some clear guidelines as well for clinicians. And also we sought advice from our legal services as well, because with the best will in the world, we want to do right by our patients, no matter what their individual needs are. But we do also then have to think from an NHS perspective as well, in terms of what are we legally allowed to do, and what are we going to get in trouble for, what are we not going to get in trouble for, that type of thing. So there was a lot to think about this individual case. And again, just some more examples that have landed on my desk. Maternity related policies. So we had a lot of midwives who felt very, very strongly that they wanted to retain gender specific language in maternity policies and guidelines. So using the term mother, woman, and the pronouns she and her. They wanted to have a statement on the front explaining that these terms will include those who do not identify as female, but they wanted to keep woman and mother. And that was actually in line with NMC and NICE guidelines. So, but we did then suggest that, look, in order to make that policy and guideline more procedure, what about if we do retain the words mother, woman, and she and her, but we also include gender inclusive terms such as birthing people and parent in the policy, so that policy does then become inclusive of all. Because like I said, here in Howell Dda, we have had some trans men using our maternity services. So those policies are not inclusive of those people. So we just wanted to include everyone there. And yes, it can be cumbersome. Sometimes you're adding to the word count of policies. But like I said, the best solution for us was to make those policies as inclusive as possible, whilst keeping everybody happy and feeling included. So we are in constant liaison with NICE to find out more about the evidence to inform their decision on policy wording. And we're also we're seeking the organisational executive decision on which stance to adopt, because just because NICE and NMC guidance saying one thing, it is okay for us as an organisation as well to take a stance ourselves and make that decision for ourselves on how we wish to take this forward. Just coming to the end. There's further reading there. Again, these slides will be sent out to you. So again, you can have a look at the legislation behind everything. There's lots and lots of different examples out there of scenarios and how best to deal with them. Like I said, it is a very, very complex issue. And I think as clinicians and medical staff, we can only try our best to be as informed as possible. In order for us to make those solutions available. And I think just to finish here, I've got my contact details there before we go on to the question and answer session. I'll stop sharing my screen. Just to finish, I'd just really like to pick up on what Tash said. And I think this is really, really key, that as clinicians, as medical staff, as people working with patients, we might not always understand a person's gender identity, but it is so important that we respect whatever that gender identity is. And I think it's the respect that's the key thing there. That's what we're trying to do. And that's why we're constantly trying to find solutions to these. Again, I hate calling them issues because it makes it sound as though it's something negative, but it's not. It's just a new way of working, and there are solutions there to be found. So that's it. I'm happy to take any questions in the panel now, and I'm happy to share any further details. And if people want to contact me outside of the session today, more than happy as well.
I just want to pick up on something you said at the end there, Catherine, just because one of the things that we've worked on recently was a report around pregnancy in trans and non-binary people, and it's the largest report in Europe and the second largest in the world. I've just posted it in the chat. It's called the Items Report, and that report actually found that 30% of trans and non-binary people didn't access any pregnancy care at all, and that rose to 46% of trans and non-binary people of colour. So we're talking about, the impact of language isn't just that people don't feel comfortable, but it's that they actually then don't access care because they don't feel safe in our care. So I think it's important to remember that language isn't just about making people feel better. It's also about signaling to them that we are able to care for them safely. So I think I've also posted in the chat the gender inclusion midwives in Brighton produced some guidelines around language and perinatal services and how to use additive language. So just wanted to plug that as well.
Thanks, Tash. Yeah, and you're right, it's about patient safety as well at the end of the day. That's why we are finding these solutions as well, because healthcare services are there for everybody. They are inclusive of everybody, and we want them to be safe for everybody as well.
Yeah, and to note, I saw someone else mentioned in the chat about being worried about not like, for example, radiation during pregnancy of trans individuals, and that is something that has happened, and that has happened already in this country. And a trans man's fetus was irradiated because nobody had asked him if he might be pregnant, and because all of the information leaflets and all of the stuff around said women should between these ages should not be scanned, and so that individual hadn't found out about that. So the Society of Radiographers actually released guidance on how to ask about those things now, so you can find that guidance online. But it's important, like, I think when we're talking about all of these things, to frame it as, you know, we were discussing the use of the term issues, to frame it as areas where we let trans people down because the system is set up for cis people, not for trans people. And so it is the responsibility of the healthcare system to adjust to that. And it is our, you know, our whole system is set up in a very binary way that doesn't work for lots of trans people, but also doesn't work for lots of cis people. You know, in the same way that trans people might not be invited for cervical screening, women who've had hysterectomy sometimes are invited for screening, and it can be really painful and uncomfortable for that. So we just need to get better at all of the ways that we give personalized care in this space.
Yeah, thank you. That was a great kind of introduction to the like forming a really good context for some of the issues which actually people will have been coming across. I can see people in the chats talking about the, you know, the actual nuts and bolts of, if you're coming to specify a system for a PAS, what should you be doing now? Do we know anywhere in the UK that's actually managed to get on top of this, that Scotland could say, look at and say, oh, that's the way that we want this to work, and that's the way that we want this to be able to do? Was it Andrew? Was it you that was writing that, wasn't it?
Come from our Tracker Clinical Strategy group in Scotland, just literally finished at 12 o'clock, and they are right in the middle of trying to write what the vendor calls a problem statement. So everything that doesn't work, we call it a problem. It's not because transgender, it's just that there's clearly a problem, and the reason is that we have for many years quietly conflated sex or sex assigned at birth on the system, and then that is displayed as gender when it's not. And I've certainly had to handle recent complaints in my own institution of the sex at birth being on the system and printed on a label that then is used for blood form. And there's a whole system issue, because I use that concept of administrative gender, which isn't necessarily very friendly, but that's how our systems are. That helps describe that's how the world is set up. The lab systems expect a binary, the radiology system set to binary, the RIS system does, and the management information downstream has that. Even on the ISD website, they do sex brackets gender, 1 male, 2 female. That's the current terminology services advice. So we are trying to write a statement to describe to the vendor, and they've recognized it as a global problem. So we are feeding into an international vendor that sells systems in jurisdictions from China to Saudi Arabia to Scotland, some in England and elsewhere. What we are doing, and our specific protections about not disclosing legal transition, might be different in those different jurisdictions. So not only we've got a UK problem, we've got to understand that global vendors will come and say, here's what we could do, but you've got to tailor it to the UK. So we could put a field for gender, we could keep sex assigned at birth, we then got a whole pile of cleaning of data to do, but then you've got an issue, you should not disclose the sex assigned at birth unless there's a reason to do so. So people are really very strangely and quite late in the day, I think, getting to grips with this, as it definitely becomes, as Tasha so very clearly stated, you know, real safety issues. If we focus on that, that might really help get traction.
It's interesting, Andrew, of course, that you are doing this. Is this to go out for a PAS to be used all across Scotland?
No, we already have a PAS used in 11 health boards in Scotland, the track care system with InterSystems. But I chair the user group for the National Sexual Health System, which again, surprisingly, although it has a gender identity module, and we look after all the trans folk coming for specialist care, that doesn't handle it really very well.
I'm wondering, does anybody know if there is, because it's interesting to think about the international comparisons, like does Iceland have a better, I know it'll be small scale, only a few 100,000 people, but have they come up with IT that actually handles this better? Or are there any parts of the world that are actually doing that better that we might be able to look to?
Yeah, I think it's a good question, isn't it? I was going to say, I think one of the problems that we have is that actually we, for a very long time in medicine, have considered sex to be something that is very, very clear and gives very clear clinical parameters. And actually, a lot of the time, we're using sex as a proxy marker for different questions that we might be rather to ask. So, for example, we use sex to ask about pregnancy, and we use sex to ask about blood reference ranges, and we use sex to ask about risk profiling. And actually, we don't know how much of that is down to sex and how much is down to gender. Like, we saw higher rates of COVID in men during the peaks of the pandemic. We don't know why that was, because we don't actually collect data on, you know, for example, gender separately from sex, or all of those different experiences. So you might have a trans man whose legal sex is male, whose, you know, hormone profile, whose anatomy profile, whose life profile is very different than that of another trans person. So I think we have got into a situation where we're seeing sex as this kind of predictive tool that answers so many questions that actually in reality it doesn't necessarily answer. And so I think sometimes people say, oh, but if we have sex assigned at birth and we have gender, then we'll have all the solutions. But in reality, I think that isn't the answer. I think the answer is that we really need to be asking the questions we actually want to know the answers to. And for a start, it would help for us to actually know whether reference ranges are the same if you've been on hormones for 5 years, 10 years, 20 years. If you've had surgeries, does that actually change the profile of risk factors? Does that actually change the profile of reference ranges we should be looking at? There's a really interesting study looking at a trans man in America who had a kidney transplant, and how the parameters for what point you consider that person within the kidney transplant parameters. Do you use a male profile? Do you use a female profile? Like, all of those things that we have so defined within medicine based on this binary actually are much more complicated than sometimes we like to think. So I think that's where we need to start. And maybe other countries, it would be interesting to look at places like Malta and Iceland, and whether there's you know, more useful systems there.
Yeah. I'm going to, Sarah has posted quite a long, detailed kind of question. Now, Sarah, would you be happy to ask that question just to the group, or do you want me to read it out?
Hello.
Or
no, I'd be really happy to ask that. Thank you. It's something that's been in my mind for a few years, really. So there are quite a lot of key common tests that we report from blood sciences, but I'm sure it's true of other disciplines in laboratory medicine as well, where we report what we would describe as sex-specific reference intervals, or different normal limits depending on whether you're male or female. That there are actually 4 sexes that are configurable within our laboratory systems. There's male, female, unknown, and pregnant. And when I kind of sort of drilled down and to see, well, what are we reporting for U and for P, unknown and pregnant, I found that there was no rhyme or reason in many cases to what we'd applied. I'm quite aware that where U is being used as a sex descriptor, it sometimes, but not always, can mean that the person is transgender, and often transgender patients are identified as male or female. So some of the instances when I'm seeing you in our system, when I look at the history, I can see through the system, I can see, oh, this is a transgender patient. But sometimes it may be somebody, you know, who's arrived unconscious and they don't know the gender, and it's an emergency code. So there are lots of uses, and it clearly doesn't meet, you know, any useful concept. But I am aware that certainly some of the use cases for this are transgender patients, and I'm really concerned about how to apply an appropriate reference interval or normal range, because I'm thinking about flagging in systems. So if we put something that's not flagging a patient as having an out of range result, when actually biologically speaking their kidneys or their liver are actually in trouble, then clearly that creates a risk that the patient's not going to be followed up, not going to be reviewed. So we've taken an approach here that where a patient has been identified as you, that we're applying the widest possible limit. So the lowest of the low limit for male or female that we know, the highest of the high. Or actually, is it? Actually, it's the other way. No, sorry, it's narrow limit. Sorry, it's the other way around. The narrowest limits. That's right. To make sure that we flag the most frequently that we can, which will inevitably give rise to some false positives, but we don't want to miss anyone, with the rationale being, well, if we flagged and it's a false positive, at least that enables a conversation between patient and clinician, which may, you know, give rise to some insight about, oh, actually this could be because of this, if the patient and the clinician are, you know, able to have that conversation, as opposed to suppressing it.
That's really interesting. So first of all, it's really interesting. That sounds like a sensible approach to if you're not sort of sure, but interesting, this workaround where people are using you for transgender, which kind of tells us things sort of in itself. But yeah, interesting workaround, and it'd be interesting to know of others. Ben McAllister has been posting a lot of very useful information in the side and has a lot of experience. I would have loved to have got Ben to give his sort of thoughts on this, but Jonathan, you also are of course the lab king. I'm going to say so. So can you?
I just wanted to follow Sarah's point.
Yes.
This session today follows a whole day discussion
yes.
At Association of Clinical Biochemistry in Wales, which is where I first realised the depth of my ignorance. Just on Sarah's point, I must add that the majority of laboratory numerical values, as seen by practitioners now, use reference values and flagging as defined within receiving clinical systems rather than as issued by the laboratory. And anyone who's trying to handle these difficult issues needs to take both ends of that into account. It's increasingly common, EPR's GP land, that what appears on the screen is not what you thought you sent.
Yeah, it feels to me like this has been a wonderfully kind of like context sort of setting issue, and we could nearly do with a second webinar or third one to get into some of these. Now we've got this established, as we've established language, we've established these issues. Let's try and think through some of the technical sort of ways of working through if we had time and everything to do it. But Ben, is there anything, you've been posting a lot of links and things in there? Have you got any comments to make or feedback? Thank you very much for your contributions.
No, just to say, I mean, there's a lot of active work going on in the interoperability standard space for this. So it would be really good to contribute to that. I know Nicholas Houtybridge is engaged in that, and I believe Kath Chilcott's been working on it in I don't know, there's an opportunity in terms of influencing in things in a UK interoperability context with the UK core fire specifications we've got. So and we can it would be good to we can move faster than the international standards and that, but it would be good to track what's going on internationally in that space. That
would be fantastic. Do you think that might be an opportunity for us to even like do another webinar and get some of those people speaking, or well, we can think about ways of following up.
Sure.
Thank you. Now I'm only down to like the last 2 minutes. Imagine we've flown through that. And starting to get some good and other kind of comments and things that are coming up there. And I think Sean, as I sort of said, they're walking through the longitudinal record with some use cases would really help. Absolutely. There is a lot. I know myself that even some of the guidance has been changed about like the issues around issuing new NHS numbers. How do you have to do this and what's actually needed? There is a lot to go through in this, and we were only just kind of starting to unpick it with this, but I think we've set a lovely context for it, and I think there is definitely enough mileage for us to be going back and review this. We're a community of people in the Faculty of Clinical Informatics who really care about these issues, and we've got the people who are involved that can actually make things better for people who are transgender. We can actually be the problem solvers, and somebody said if you're in clinical informatics, you're a fixer and a facilitator, and that's what we can take on, that role of trying to help solve these very, they're difficult because of the way the systems have been set up, as we've said, and I think that's it's been a great sort of start, and I'm really proud that we've been able to have this conversation. I think Tash and Catherine, you did a fantastic job in bringing that through, and I'd like to say a very big thank you to you, and also to Ruta and Lorenza for actually making this happen. Our staff always do a fantastic job in keeping us to time and all the rest of it.